Hi, everyone. Welcome to the All Things Amyloid podcast, where we feature patients, caregivers, and clinicians who discuss amyloidosis, a rare and incurable disease. Amyloidosis occurs when the body builds up abnormal amounts of misfolded amyloid protein, which can lead to serious and life threatening outcomes. I'm your host, Mackenzie, an amyloidosis patient and founder of Mackenzie's Mission. Our goal for this podcast is to raise awareness and share firsthand what it's like to live with this disease, to care for those affected by it, and to treat it. We hope this leads to earlier diagnosis and start of treatment, which will improve patient lives. What if you're a doctor and diagnosed with amyloidosis, and now you're the patient? In this episode, we'll be talking with Dr. Charles Schulman, a cardiologist. He was on staff at Beth Israel Deaconess Medical Center for over 53 years until he retired in early 2024. Back in 2020, he was diagnosed with wild-type transthyretin amyloidosis with cardiomyopathy. It's an interesting situation to be in, with lots of questions to understand how a doctor impacts your experience as a patient, and vice versa. Charles, welcome to the podcast. It's so great to have you with us today.
Oh, thank you, Mackenzie. It's great to be here.
What a fascinating story, and I'm sure one that our listeners will find very interesting. Perhaps we start with while you are a practicing cardiologist and you began to first develop symptoms.
That was probably late 2019 and early 2020, before the pandemic. I developed carpal tunnel syndrome with numbness and tingling in my fingers on both sides, but my right hand was much worse than my left hand. And it progressed to the point where it actually became painful.
Hmm.
I was unable, for example, while working in the clinic, unable to use a computer mouse for more than 10 or 15 minutes at a time because my hand would get numb. So I consulted with a hand surgeon who offered me either an injection or curative surgery.
Mm.
She advised me to just have the surgery, and I agreed. I didn't have any other symptoms at that time. I was fully active. I was practicing. I was on a reduced schedule anyway, so I had 2 clinic days, but they were full days.
Mm-hmm.
8:30 to 5. And I was seeing patients and I was teaching. So the activities themselves weren't impacted, but my documentation was.
Certainly suffered a bit. So as you were starting to deal with these new symptoms that were cropping up, were you using your clinician hat, so to speak, at all to try to think about what may be going on?
I mean, it was pretty obvious to me that I had carpal tunnel syndrome.
Sure.
And that it needed it needed something. In terms of the biopsy itself, it was I saw the surgeon in February of 2020.
Mm-hmm.
And scheduled surgery was delayed by the pandemic until June.
Mm-hmm.
So the delay in my diagnosis was really not because anybody overlooked it, because nobody considered it, or because people didn't know, or anything like that. The situation that is the case for many of our patients, as they explained to us, but it was delayed by the pandemic.
Sure.
And then around the time, I think it was just before the biopsy, as a matter of fact, I developed paroxysmal atrial fibrillation.
Mm-hmm.
So I consulted with the atrial fibrillation guru at the Beth Israel Deaconess Medical Center and started on Eliquis.
Mm-hmm. I just want to go back because I think that's really interesting. You mentioned that you had the carpal tunnel release surgery. You asked for a biopsy, but take us back to when, maybe how you realized that that was something that you needed to ask for, or
Um, well, there had been an article by the group at the Cleveland Clinic, which was published 2 years prior to that in the Journal of the American College of Cardiology, which I read on a regular basis,
Mhm.
um, uh, where they took 100 people who underwent carpal tunnel surgery with no other clinical symptoms and did biopsies on them and found out that 10% of them were positive. Knowing that, I asked the surgeon to please do a biopsy.
Mhm.
She did the biopsy. The biopsy was positive for Congo red stain, which is the typical positivity that shows that you have amyloid.
Yeah. So it's kind of interesting that, I guess, if you hadn't had the medical training and the education that you do, you wouldn't have thought to ask for the biopsy.
I wouldn't have known it.
Yeah. So would the surgeon have done it instinctually? Would they have even known? Maybe you wouldn't even know you have amyloidosis until many years later.
That's all correct.
Yeah.
Uh,
So,
I'm fortunate that way
mhm,
because it was possible to make the diagnosis at an early stage.
yeah. No, I'm just curious. You found the article about the carpal tunnel release surgery, but you're obviously a cardiologist, and I would presume that you spend the majority of your time reading articles that surround your specific field. So, how did you come across the carpal tunnel release and the amyloid? Were you seeing amyloid in your clinic at that time? Was it something that people were talking about, or did you just stumble upon this article and think, "Man, this could pertain to me"?
Uh, number two.
Interesting. Uh,
Number two, I didn't think about amyloidosis at all before that.
mhm, interesting. Interesting.
And people in the no people, I was at the time I was working in a general medical clinic.
Mhm,
The Beth Israel Deaconess Medical Center has a clinic in Chelsea, Mass, um, which is 20 minutes away
mhm.
from the main campus on the other side of the Boston Harbor.
Yeah,
So, but nobody thought about it at all.
interesting. I mean, I can certainly understand that. So, now, kind of shifting gears, you've gotten, I presume, the results from the biopsy. You found out that it stained positive for Congo red, that you very well could have amyloidosis. And talk about that moment. How did you feel as a doctor realizing that you have now just become a patient with a very serious disease?
Um, well, there were two kinds of reactions that I had at the time. As a physician, I reacted by saying, "Well, okay, we have a diagnosis.
Mhm,
What's the next step in terms of diagnostic testing?"
mhm.
As a patient, my first reaction was, "Oh shit." um, but finding out that you have something that's unknown,
Mhm,
that you have no idea what's going to happen to your life as a result of this. I'm not. I wouldn't use the word devastating,
mhm,
because I never reacted to it that way.
mhm.
But it certainly it has carries the implication of a life change.
Sure.
So, as a patient, just like every other patient, you become somewhat anxious about it.
Hmm. Yeah. So then I presume you proceeded with more testing, and so take us from there.
Well, I had an echo,
Hmm.
which surprised me in that it showed that I had left ventricular hypertrophy, which of course I never knew before. I had no reason to have an echo.
Hmm.
I had a cardiac MR, which is not a fun test to have, incident.
Mm.
Um, and then the workup goes that you have once the cardiac MR was suggestive of an infiltrative cardiomyopathy.
Hmm.
The next step is to do a serum protein electrophoresis. I did not have light chains
Hmm.
and therefore had a pyrophosphate scan. That test was much easier to take than the cardiac MR, and so the pyrophosphate scan was very positive.
Hmm.
Genetic testing was done, which was negative, and so the diagnosis of wild-type uh, uh, cardiac ATTR amyloidosis was made.
Sure.
Now, at that time, the only treatment that was really approved for that was tafamidis. And so since September 1, it's my 4-year anniversary, actually. Uh, since September 1 of 2020, I've been taking tafamidis every day.
Hmm. So, how do you think being a doctor impacted your behavior and your mindset as being a patient? So, how might you be different from other patients who aren't physicians, who don't have the medical training that you do, um, that compared to them that you see every day?
Well, a couple of things. As a physician, I'm able to read the medical literature,
Hmm.
uh, have access to the medical literature. That has pros and cons.
Hmm.
The pros are that you can learn about things in a scientific and unbiased way.
Hmm.
The cons are that the Kaplan-Meier curves of survival are sitting there staring at you in the
Hmm.
face, right? And
Yeah.
so you know what median survival is, and so I reread the ATTRACT study, that study of tafamidis that proved that it was effective,
Hmm.
and for which the FDA gave the drug approval.
Hmm.
Um, I reread it because I wanted to see where in the spectrum of patients that they tested I was.
Interesting.
See, so it was somewhat relieving for me to know that I was on the milder end of things, that most of the patients in that study had already had heart failure symptoms,
Hmm.
uh, and so the survival is I thought I was on the better end of the survival.
Sure.
Well, in addition to that, right, I'm in my mid 80s, and there are many competing uh, comorbidities that affect people that affect octogenarians and nonagenarians,
Sure.
besides whatever their main diagnosis is. So there are competing forms of, causes of death,
Hmm.
put it that way. Um, so you never know.
Yeah.
Um, Subsequently, I came to learn, I think from the Amyloidosis Center group in London, that people that I resemble, let's put it that way, in terms of the level of biomarkers,
Hmm.
um, lived and treated lived. Their survival was not far different from um, the survival without the diagnosis. So that was encouraging.
Hmm.
that's, that's as a physician,
Yeah.
as, but as a patient, um, I'm no different than anybody else.
Yeah.
I become anxious, uh, when there's an upcoming test.
Of course.
I think you're probably more familiar with that than I am.
I can certainly empathize with you.
The approach, I never thought about that before.
Hmm.
As the test approaches, you become very anxious in terms of, is this going to change my life?
Yeah.
And then when the comes out okay, then there's a great sigh of relief. I have to take medicine. I take, I don't know, a dozen pills a day, and various medications. Um, I have to remember to take them. I have to remember to be sure to have the prescriptions refilled, um, just like everybody else.
Yeah. So tell me a little bit about, I mean, I'm curious to know, you were obviously at Beth Israel at the time, even if you were kind of reduced hours, but you were still at Beth Israel, and talk about how that may have provided a pro in terms of being a physician, maybe access to resources or things that patients who don't aren't a physician or don't work in a medical system might not access.
Well, I feel all of my medical care has been at Beth Israel.
Hmm.
Um, so, I mean, I had cataract surgery, for example, that has nothing to do with this. Uh,
Hmm.
but and I have an appointment on Friday to see the ophthalmologist. But um, I feel very comfortable there, and that's a definite pro. People know, people know who I am.
Hmm.
Okay, I've been around so long that some of the residents will say that they remember. Some of the attendings will say that they remember that they took one of my classes
Yeah.
when they were a resident.
Hmm.
So that's a good feel. That's a good feeling.
Sure. Of
Um,
course.
and I'm able to advocate for myself. That's
Hmm.
a big thing that a lot of people aren't so good at,
Yeah.
and don't know that they have to, you know, stand up for themselves. I mean, I put it stand up for yourself, but really it's advocating for yourself. Uh,
Yeah.
People are not aware that they're able to, for one thing.
Yeah. That's a great point.
All the doctor says, this, and they say, yes, sir,
Yeah.
instead of saying, would you explain that to me?
Yeah.
Or tell me your line of thinking. Why are you thinking that? Why do you think that? What are the options? Um, I'm fully aware of being able to advocate for myself.
Yeah. Yeah. I think, having medical training allows you to understand that advocating for yourself as a patient is okay. Right. I think a lot of patients who don't have medical training maybe feel that inferior is not the right word, but
They're afraid.
they're afraid. And I think they're afraid to come off as rude or kind of challenge uh, a doctor's decision making or line of thought when they themselves don't have any medical training. They don't have the confidence necessarily to ask questions and ask for those explanations, like you said, because you don't want to come off as rude. You understand that your knowledge is far limited in comparison to the person sitting in front of you. And but I think it's really important for patients to understand, just like you said, that it is important and it is okay to advocate for yourself and be a part of that decision making process when it comes to diagnosis and treatment and all the things that come along with having a disease.
Well, uh, for a number of years, we're as physicians, we're now much more into what's called patient-centered care
Hmm.
and shared decision making.
Sure.
So there are institutional uh, there's an institutional push, I'll use that word, to involve the patient, you know, and you get, from patients, you get various kinds of responses, you know, uh, you know, one type of response is whatever you say, doctor,
Mm-hmm.
I'll do.
Mm-hmm.
Another one is, I don't know. I don't know the difference. What is the difference?
Mm-hmm.
Uh, and the other one is, I don't want to do that.
Yeah.
That's not important to me. Whatever it is that you want to do is, not important to me. And some people are just plain stubborn.
Mm-hmm.
It's inconvenient. It cost can be a factor for a lot of people.
Yeah.
So that becomes a big thing,
Mm-hmm.
and has received much more attention in the last few years, and certainly in a number of the cardiologic guidelines.
Sure. So I want to touch on one more thing before we move on. Obviously, one of the big parts of your, not necessarily training, but maybe continuing education, or just being a physician in general, is attending meetings and conferences to stay up to date with what the latest happenings are in your field. And one of the huge benefits of attending those kind of things is you have access to experts.
That's right.
So, if you could elaborate on that a little bit and kind of the value that played in your story.
Well, well, well. That's one of the advantages that I see, that
Mhm.
I feel fortunate to have. Really, that I feel fortunate to have in terms of my diagnosis,
Mhm.
is to have access to some of the experts in amyloidosis. Um, uh, I have spoken with. So my doctor is at Beth Israel.
Mhm.
There is a small cohort of patients. I shouldn't say small. I don't know it depends on how you define small, but
Mhm.
it's a cohort of patients of perhaps 100 or so at Beth Israel that Dr. Pablo Quintero uh, uh, oversees that program.
Mhm.
But I was in contact with Dr. Rick Ruberg at Boston University's Amyloidosis Center. He has
Mhm.
a large amyloidosis center. Um, he happens to be a friend of my stepson, but you know that's beside the point. So I've spoken with Rick, and I'm able to ask Rick, what should I do something different?
Mhm.
Should should I take this or that or the other thing? Um, I've been at the meeting when the idea of taking a drug like Jardiance was presented, or was talked about. I went to one of the big meetings. I can't remember if it was the American Heart Association or the American College of Cardiology, but there was an amyloidosis session, so I went to the amyloidosis session.
Mhm.
I directly asked Matt Maurer, who runs the Amyloidosis Center at Columbia,
Mhm.
what he thought of that.
Yeah.
I asked there was another fellow whose name I've forgotten, from Stanford. I asked
Mhm.
him. Everybody gave me the same answer, so
Hmm.
I take Jardiance.
Yeah, it's definitely priceless to have access to some of the brightest minds in this field. So, in contrast, the flip side of the coin now, how do you think being an amyloidosis patient impacted your cardiology practice? Did it have impacts on your relationships with your patients?
Not really.
Mhm.
Well, not on my relationship with patients. I have had relationships with patients that stretch over 50 years. I don't have too many patients who were my who were my patients in the beginning, because
Mhm.
unfortunately they've passed on. But so I have these long-standing relationships, and the diagnosis of amyloidosis, didn't change any of that.
Yeah.
One of the things it did do, however, was make me aware of considering the diagnosis in my patients in whom it may not be so obvious.
Sure.
So if I had patients, for example, that had left ventricular hypertrophy, thick left ventricular walls on echocardiogram, I would think, well, could this be amyloid? So I would do a serum protein electrophoresis and, thinking about some of the other characteristics of the patient, age, sex, wild-type ATTR amyloid is a disease of old white men. So I have a lot of patients who fall into that category. So, a 70-year-old or 75-year-old with left ventricular hypertrophy like this, who did not have terrible hypertension, I would think, should we do the testing? And so I went about testing, ordering serum protein electrophoreses and pyrophosphate scans. And a number of them were negative, but there were several that were positive.
Yeah. So if you put your patient hat on, what would you recommend or suggest physicians should know, or if there's anything they should do when they're dealing with patients that are diagnosed with a rare or complicated disease?
Well, in the first place, I go back to what Sir William Osler said in 1905. He said, "Listen to the patient. He is telling you the diagnosis." In those days, the only way to make a diagnosis was to talk to people because there were no tests.
Sure.
Okay. Today, that has a different meaning for all of us. But listen to the patient, find out what bothers them, and then try to think about the red flags and consider amyloidosis at an earlier stage of patients' course. I'll give you just a little aside example of that. A friend of ours, a woman who was in her, I don't know, she must be in her early 70s, has had diarrhea and has been losing a lot of weight, and she doesn't know why. I don't take care of her. I don't know her doc. I mean, I actually know her gastroenterologist at Beth Israel, but I don't know anything, but I say, oh, well, those might be symptoms of AL amyloidosis. Ask your doctor to do a serum protein electrophoresis. That's the idea. Trying to think about the diagnosis of amyloidosis.
Sure.
Right? If you never think about it, you'll never make a diagnosis.
Absolutely. That's a great quote. And then what about for physicians after they've made the diagnosis? Is that they've identified amyloidosis, they're ready to diagnose their patient? Any words of wisdom for them in that setting, or things that they should really be focusing on when they're having that discussion with their patient?
It's important to get people treated. So if there are amyloidosis specialists or heart failure specialists or cardio-oncologists or oncologists at your hospital, then perhaps an appropriate referral should be done.
Mm-hmm.
I think there's a push to refer people to some of the larger amyloidosis centers. But as we find more and more amyloidosis, I think we're going to find more and more people treated outside of those centers. If you're, I spoke with one fellow who lives in Montana. Well, he was referred to Mayo Clinic. See, the people at his hospital were not, were not an amyloidosis center, didn't have many patients, and weren't really up to date on what should be done. So he was referred to one of the amyloidosis centers. It's not necessary in many places in the United States. If there's a question and if it can be done easily, then you should refer the patient to an amyloidosis center. Another thing is to try to help people to become advocates for yourself. We've been talking about that.
Mm-hmm.
People should know that they're not alone.
Mm-hmm.
That there are support groups. There are a number of nonprofit organizations and support groups like the amyloidosis support group that Muriel Finkel runs. Is very helpful to. They gather patients and are very helpful in trying to enhance the experience of patients as they receive the diagnosis, as they take the treatment, as they live through the treatment, and carry, and try to carry on their lives.
So how would you assess the level of knowledge in regards to amyloidosis that's amongst the cardiology community today? Have you seen changes I'm not exactly sure how to put this, but maybe like the volume or kind of the attention that amyloidosis gets now in the cardiology field compared to, say 5-10 years ago?
Well, it's certainly increased. I can't speak to the cardiology community, and I certainly can't speak to, let me put it this way. In Boston, we're fortunate because there are, three major hospitals that are affiliated with Harvard. One of which, the Brigham and Women's, has an amyloidosis center. There's Boston University, Boston Medical Center, which is a university hospital that has an amyloidosis center. There's Tufts University School of Medicine, and Beth Israel. So we're fortunate to have many resources for people. Other cities are not so fortunate. It depends, and certainly the more suburban, well, not so much suburban, but in the rural areas, it's not so easy. Just as an example, I can think of Western Massachusetts.
Yeah.
There are a number of, there's a hospital in Springfield, there's a hospital in Pittsfield, but not the same.
Yeah.
I would advise people to avail themselves of whatever resources they can reach.
So, in closing, any comments for clinicians about their chances of seeing amyloidosis and how they can be sure that they think about and keep amyloidosis on their differential?
Well, I think someone said, "You may not see it, but it sees you."
That's a great quote.
I think it's going to be more and more common. I think as people realize two things. one thing is to look for it in patients who have heart failure with preserved ejection fraction.
Mm-hmm.
Other one is to think of it in patients who are newly diagnosed as having hypertrophic cardiomyopathy, and people, meaning older people.
Mm-hmm.
Older people, because a certain percentage of those people are going to turn out to have amyloidosis, not hypertrophic cardiomyopathy.
Mm-hmm.
Amyloidosis as a separate section was added to the ACC AHA guidelines in 2022 for the first time.
That's wonderful.
So there's a section in those guidelines devoted uh, uh, entirely to amyloidosis.
Mm-hmm.
So that's going to increase, knowledge and awareness. The other thing is to be aware of the red flags. Somebody has carpal tunnel. The red flags for ATTR amyloidosis are carpal tunnel syndrome, um, lumbar spinal stenosis, biceps tendon rupture,
Mm-hmm.
things like that. Some of the red flags for AL amyloidosis the nephrotic syndrome in people with heart failure,
Mm-hmm.
and the pathic mnemonic. I think you don't see this you don't see very often, but it was highlighted. There was an image in the New England Journal of Medicine about 2 weeks ago.
Mm-hmm.
Purple around the eyes and what's called macroglossia,
Mm-hmm.
large tone.
Yeah.
If you see anything like that, or you see biceps tendon rupture, think amyloidosis. Speaking of biceps tendon rupture, I once had a patient who had that.
Interesting.
He was the father of my office manager,
Mm-hmm.
talking about 40 years ago.
Yeah.
Nobody knew anything about amyloidosis back then, and I have no idea if he had it or he didn't have it. He had
Certainly makes you wonder, though.
he had coronary disease, however.
Yeah.
But I thought that was such a strange thing. It stuck with me all these years. So looking for the red flags, considering the diagnosis, I think is important for physicians. Certainly from the patient's point of view, it's important because you come to the diagnosis and there are treatments both for ATTR amyloidosis and for AL amyloidosis. So whichever kind of amyloidosis you have or you turn out to have, there's treatment for it. And we should all be aware of that and try to steer patients to places where they can get the appropriate treatment.
Well, Charles, it was an absolute pleasure to have you on with us today, and thank you so much for sharing your journey as both a physician and an amyloidosis patient.
Thank you. It's a pleasure. It's a pleasure for me to try to help other people. One of the things in my retirement is that I'm trying to give back, so to speak, and try to help other people. And if I can, I have a special interest in amyloidosis, as you can imagine.
Slightly biased.
And I'm happy to try to help.
No, absolutely. I think there's a lot of really valuable messages for our audience in there, and as for our patient audience, doctors that become patients experience emotions and the same challenges that the rest of us do. So it's just a valuable thing to keep in the back of our minds. Thank you for listening to the All Things Amyloid podcast. If you find our podcast informative, please follow and share it with others. If you want to learn more about the work we're doing at Mackenzie's Mission, please visit mm713.org. We'd also like to thank AstraZeneca Pharmaceuticals, Alexion Pharmaceuticals, Alnylam Pharmaceuticals, and Bridge Biopharma for their sponsorship to help raise awareness about amyloidosis. We hope you stay tuned for future episode drops. Thanks for listening.